Welcome to Wu University's Great Contact Lens event. It is so exciting to be kicking off this series with a very good friend of mine, Dr. Tom Quinn. My name is Dr. Stephanie Wu, and I am the founder of Wu University, and I will be your host for this evening. It's now my pleasure to introduce tonight's speaker, Dr. Tom Quinn. Dr. Quinn and his wife, Susan, established a group practice in Athens, Ohio in 1983. He has served as the chair of the American Optometric Association's Contact Lens and Cornea section, and he's also a diplomate of the Cornea, Contact Lens, and Refractive Technology section of the American Academy of Optometry. Dr. Quinn is also a fellow of the Scleral Lens Education Society and an advisor of the Gas Permeable Lens Institute. He's also a past recipient of the GP Lens Practitioner of the Year Award. He's also chaired the East-West Eye Conference, and he serves on the Educational Advisory Board for Vision Expo. He was the 2019 recipient of the American Academy of Optometry's Vincent Ellebrock Clinician Educator Award. Dr. Quinn is not only a wonderful doctor, but an incredible person. He has many different talents. It is a joy to know him, and I think you guys are going to learn a ton on multifocal contacts. Welcome, Dr. Quinn.
Thank you, Dr. Wu. I'm just thrilled to be here. Thank you so much for inviting me, and everyone that's tuning in, thank you for being here. We're going to talk about my favorite thing, contact lens thing to talk about, which is discussing multifocal contact lenses. Before we get into it, I want to give my financial disclosures, and nothing should be impacting the content today that would lead you to think I'm biased in any way. This is all about how to approach multifocal soft contact lens fitting in a very holistic way. And I'm going to do that by approaching it and thinking of approaching the multifocal patient using the art, because anyone that's attempted fitting multifocal contact lenses in the past knows that there's art behind it. And we're going to talk about some of those new nuances, but also there's science that forms the foundation underneath that art. So let's kick things off by talking a little bit about what science says regarding multifocals versus monovision. We had a lot of interest in the scientific community looking at this question, and back in the 2000s, in the early and mid 2000s. And I want to just quote a few of those studies. I have them here on the slide. And the message I'm communicating here is that about 7 out of 10 patients, when they compared in head-to-head studies, monovision versus multifocals, 7 out of 10 preferred multifocal correction. Now you may say, well, wait a minute, Tom, at the bottom there was a study from Dr. Woods up in Canada in 2015 that showed a 51% preference for multifocals over monovision. But if you look deeper into the numbers, you'll see that 12% didn't like either. So the number of people preferring monovision still remains in the 30% range. So if you're playing odds, science tells you go for a multifocal because 7 out of 10 patients are going to prefer that option. Now, I suspect there's a few of you out there looking skeptically at your computer screen and saying, well, that's not been my experience with multifocal contact lens correction. And I suspect there are a few reasons why that attitude may persist in the field. And we're going to touch on those right now. First of all, the idea that a multifocal contact lens doesn't perform well at near and low light is well known. We know that. And the very studies that showed the 7 out of 10 patients prefer multifocal lenses are the same studies that showed us under low light at near, these devices don't work as well. So let's not throw the baby out with the bathwater. We know that there are a lot of benefits of multifocal lenses that the 7 out of 10 people prefer. Now let's arm them with the tools to recognize, first of all, let them understand that this is potentially an issue, then arm them with the tools to manage that issue. And those tools are magnification and light. And you can get apps, but the phone has a light on it. At the restaurant, everybody's got a light in their pocket. So it's an easy problem-solving strategy. You just want to practice what I call the no surprise approach the fitting multifocal contact lenses, and that is letting people know that this may be an issue in a dimly lit restaurant on a romantic evening with their special someone, and just arm them with the tools to manage it. That is with light and magnification. So to set the stage for success, number one, know the science, know that 7 out of 10 patients prefer multifocals to monovision. And what that should do is give you confidence in knowing that when I recommend a multifocal option to a patient, I'm doing the right thing. Science backs me up on this approach. It's the right thing to do. Most patients will prefer it and do best with it. But also know the strengths and weaknesses of the multifocal options, such as the near vision and low light. But appreciate the benefits that come with the multifocal correction. I had an epiphany a number of years ago where I had a patient, Bob was his name, and he was a wonderful patient. He was approaching his 40s, wearing single vision contact lenses. I saw him, he was doing great. I sent him on his way. I said, we'll see you again in a year. 4 years later, he returns and says, I've dropped out of contact lenses. He shows up wearing his glasses. And I said, what happened? He goes, well, he's a myope. And he said, I realized that I was having trouble seeing up close with my contact lenses, but if I wore my glasses, I could just look under my glasses and see up close. And I said to myself, Tom, you let this patient down because this patient didn't know this was coming. I never told him this was coming. So ever since then, I've been very adamant on preparing the pre-presbyope for this eventual change that's going to happen. We all know it's coming, but they may not and probably don't. So now my practice is when I have that 39 or 40-year-old myope who's not having any symptoms in my chair, at the end of the exam, I say, you're doing great with your single vision lenses. I want you to know that your vision is changing. You'll notice some issues with your close vision in the coming years. When that happens, come in and see me and let me know, because I have devices that can help you with that. I have special design lenses that allow you to see far away and up close. It's just turn the table on that. So instead of an unnecessary dropout, I have people seeking me out for multifocal correction. This is to tell us that presbyopia is not a surprise to us, but it may be to your patients. So make sure you prepare them. Okay, the next step for setting the stage is fit them early. So often in our profession, what we've done is fit monovision. So let me set the stage here. A patient comes in, they're 43 and they're wearing single vision contact lenses and they're having issues with the close vision. Historically in the past, what we would do is put plus 50 in front of one eye. Is that better? Yeah, okay, make that change and send them on their way. They come back the next year, we do the same thing. And the next year, the same thing, and again and again and again until they're in full-blown monovision. Are you with me? Been there? So they're in full-blown monovision. Now they come in with complaints that come from full-blown monovision. Issues with night driving, issues with depth perception, issues with intermediate vision, because we have two eyes but work at 3 different distances. Then what do? Then oftentimes the multifocals are reached for. And we know that the higher the add in a multifocal contact lens, the greater the potential for it to disturb far vision. So what we've done is made our job a lot harder. When we take that advanced presbyope and try to start there with multifocal correction, that is a challenge. And that is why some of the practitioners out there view multifocals as tools that don't work that well, because that's when they start to employ them. I want to implore you to start fitting multifocal lenses early. Fit those early presbyopes. And you may say, Tom, wait, I could just do a plus 50 in front of one eye and that solves the problem. It's cheaper for the patient, it's quick. But I implore you to invest in this patient's future by fitting them with a low add multifocal, get them adapted to multifocal optics in the low add, and then as their presbyopia increases, then you make modifications to the add and they're able to adapt to it much more easily. So fit them early. My final comment is twofolded. One is define success for your patient. Think about the single vision contact lens patient. Those single vision contact lenses have met that patient's every need at every moment. So they're a little bit spoiled. When it comes to multifocal correction, the rules change. And these rules change for any presbyope, whether they're a contact lens wearer or a spectacle wearer. In our practice, anybody that tells me they're on a computer for 6 hours or more, I'm talking about computer glasses. So multiple tools are necessary for spectacle wearers as well as for contact lens wearers. So don't assume that contact lens wearers need this special care where spectacle wearers don't. It's part and parcel of a piece of the presbyopic puzzle. So they're going to need multiple tools, the magnification, the light, the apps, so as we discussed already. So, and I set the stage, and we're going to talk about key phrases in managing multifocal correction. But one of the key phrases I always say is, my goal is to meet most of your visual needs most of the time. Not all your visual needs all of the time. So that's the subtle underlying message. And again, this is the case that comes along with being presbyopic. The final recommendation is to define success for yourself. When you step back and say, okay, when do I stop and say, I have a successful multifocal contact lens patient? What do you use in your mind? What thought process are you going through? Well, I want to use a great study that was done by Jill Woods up in Canada a number of years ago that looked at measuring performance both objectively and subjectively. Looking at objective measurements, that is, looking at acuity measurements, monovision outperformed multifocals. But when they asked patients what device, multifocals or monovision, serve your needs better for your day-to-day activities, multifocals won. So I encourage you to not use acuity measurements as your barometer for success with a multifocal contact lens patient. Use the barometer of success when the patient says, yeah, I can do most everything I need to do with my contact lenses. And the trick is finding the right balance. So understanding how the patient uses their eyes and understanding what distances are key are really important as you go on the journey of seeking out the proper powers for that right balance to meet most of the visual needs. Let's talk a little bit more about some of the key phrases in multifocal contact lens fitting. I've already shared this one with you. Another one is fitting is a process. I share this statement with every patient when I embark on multifocal lens fitting. The reason I do this is that we know that sometimes nuanced adjustments need to be made to multifocal contact lenses to get them to perform right, to meet those various needs. They're unique for every patient, right? So we're never going to be able to know for sure what the final prescription is until the patient gets out in their natural environment, doing what they do, viewing things that they need to see before we know the exact power, because we may find we may need to make a little nuanced change. So I want to prepare the patient for that. So if they come back and I need to make a change, they're not losing confidence in me and thinking, he doesn't know what he's doing. Look, he's got to change things up. So that's an important message to get across from the get-go. It's also very important to say the visual system needs time to adapt. And this is a statement I'll make sure I say if I have a patient that's saying the first time multifocal contact lens fit, and they're saying, you know, things seem a little odd or a little different. And I confirm the power, which we're going to talk about here in a minute. So I feel confident I got the right power and that they just need to adapt to the multifocal optics. I want them to know that there is science to support that visual acuity with multifocal contact lenses does improve with time. And here's 3 studies here that you're welcome to look up. But I want to talk mostly about the bottom study that Fernandez did, where he took monovision people and multifocal people and followed them over was a 15-day period. And over that 15-day period, acuity improved with the multifocal patient and did not for the monovision patient. So I know that in the past, we've thought that people of my age maybe were hardwired, our brains were hardwired by this point in our lives. So presbyopes just didn't have any ability to have their brain adapt. These studies say that that is not the case, and that in fact, presbyopes do have it. They still bring that flexibility and the ability to learn and adapt to multifocal optics. So many times patients will say, I don't know, things seem a little funny. You say, go out there, wear the lenses, experience real life, and commonly they'll come back and say, oh, okay, yeah, it's fine now, because their brain has adapted. Another key phrase is small changes can make a big difference. I think most all of you, if you're on this webcast, that you are fitting multifocal lenses and you've experienced that a quarter diopter change can make a huge difference in performance and can be the difference between success and failure. So letting patients know a little bit of nuance change can be really impactful. Light is your friend. We've talked about the importance of light, particularly in near. But I'd like to tell patients this up front. So again, as we discussed at the outset, it's a really important point to communicate. And when patients come back, commonly when they, I use just this phrasing, light is your friend. When they come back for follow-up, I'll say, so how you get along? They go, well, I'm doing pretty well. I've learned that light is my friend. And we chuckle about that. It's a phrase that really locks in with them. So I encourage you to use pretty much that exact wording. It's worked well for me. These lenses are designed to work together. Why do you think I would share this notion with the patient that I'm fitting newly with multifocal contact lens correction? It's because oftentimes, particularly for the more advanced presbyope, we're fitting unequal correction in each eye, right? We're putting a higher add in one eye or pushing plus in front of one eye to get the near vision that we need. And that difference can be concerning to a patient who does this. So I let them know right from the get-go, these lenses are designed to work together. So I even will say, so don't compare one eye to the other. How do you perform with both eyes open, which is how you function in your day-to-day activities? That's what's important. So what are some of the key examination procedures and techniques? Let's talk about that. Here's some tips on assessing vision with a multifocal contact lens patient. So in our office, we do a detailed refraction. Let's take a second and just talk about what a detailed refraction is. A detailed refraction is, come into the lane with me here. So I got a patient behind the phoropter and I say, which is better, 1 or 2? And I give them a quarter of minus. And they go, oh, 2. Okay, that's good, right? They're going to keep that. But what if I have a patient that I give them an extra quarter minus, which is better, 1 or 2, and they say, 2. They're not getting that. They're not getting that because I don't want to give them any more minus than is absolutely necessary to give them clear distance vision. And if that extra quarter minus is not giving me a meaningful boost in acuity, I'm not going to give it to them. The reason is the more, if I over minus at distance, then I have to over plus at near to get the near acuity. And now I've created a bigger difference between distance and near powers, and they're more likely to conflict with one another. My goal is to keep those two as tightly together as possible. So the lowest add possible is the least likely to be problematic with distance vision. So that's a detailed refraction. Having said that, once I have a detailed refraction, I'm going to the fitting guide and following it to choose my first pair of lenses. I'm going to put those lenses on, those diagnostic lenses on, and in our office, the patient is required to leave the examination lane because they don't live in the examination lane all day like we do. They live in the real world. So they go out into the reception area and they're invited to look out the window, pick up a magazine, explore their visual world. And what they're doing while they're exploring their visual world is doing my work for me. Because then when they come back, into the room, I walk in and what do I say? I say, how are you doing? How you doing with your multifocal contact lenses? A very open question. And what that does is it gives the patient the power to now direct this conversation. Because if I walk in and say, how's the vision with your right eye? How's the vision with your left eye? How's the vision when you stand on one foot? It gets complicated. Where when you give the patient the power to direct the conversation, they will zero in on where the issues are. So if I say, how you doing? They go, well, I can see far away fine, but I'm having trouble up close. This is where I'm going to focus my energies to solve that problem at near. So it got right to the issue right from the get-go by using open-ended questioning. This next statement is something I hope all of you know, is that when we do testing with multifocal contact lens patients, we want to mimic a real-world environment. We want their pupils and their accommodative system to be as they will be out in their natural environment and what their common tasks are involved in. So we're going to have the room lights up. We're not going to use the phoropter. We're going to test vision binocularly. We're going to use real world tasks as we test their vision. And if we want to make changes, we're going to use loose lenses, again, not the phoropter. Checking the VAs. Okay, let's set the stage properly here. We're going to check binocular acuities, as I mentioned on the last slide, but it's really important to start, have the chart at the end of the room set up at 20/40. Why do I say that? Well, what do we normally have projected at the end of the room when a patient presents? Normally have the entire acuity chart, right? And at the very bottom is 2020 or 2015. So imagine you're a patient wearing multifocal contact lenses for the first time. You're out in the reception area and you're thinking, oh, this looks pretty good. But then you go into the examining lane and you sit down. What's the first thing you're going to do? You're going to try to read that very bottom row. And if you can't, you're discouraged. So what we do is turn the tables on that and we isolate the 20/40 line before the patient gets into the room. The patient enters the room, they sit down, they look at the chart, they can read that. Why do we say 20/40? Because in most states, I know in Ohio anyway, you need to be able to see 20/40 to drive legally. Also, I picked 20/40 because I'm almost certain they're going to be able to see that. So they read the 20/40 line. They say, oh, that's good. Let's go to the next line. They go to 20/30. They can read that. Well, that's good. Then we go to 20/25 and they can read that. And then we go to 20/20 and we think, oh, this might be difficult. This is small. But if they read it, it's like, high fives sort of all around the room. See how we've turned the tables and now we got success after success after success. And the patient's feeling confident that these lenses will work for them. Again, have the lights on to mimic natural environment, use real world tasks. If the patient has no complaints, stop. Send them on their way and have them back in a week or so to see how they're doing. We optometrists tend to be very numbers oriented. And if a patient's reading 20/20 minus, we want it to be 20/20. And we might tend to want to intervene, perhaps add minus to the distance correction to pick up that extra letter or two. But in the process of doing that, we might upset the apple cart, upset the balance that we need to meet all the different visual demands. So if the patient's doing well, don't make a change. Too often a change is made there that's not necessary and it upsets the apple cart. Okay, let's say a patient, we do all the things that I've discussed. The patient comes in and they're saying after wearing them for a week, for example, and they're having problems, how do we help? What are some tips on troubleshooting? The first tip is to always confirm you have the proper distance power correction. In my experience in talking with practitioners, too often they go to the fitting guide and start manipulating add powers. First, confirm that you have the right distance power. And you may be surprised about how often patients will take more plus power than what you might expect based on what their spectacle prescription is. And the reason is due to the aspheric optics of these lenses. Oftentimes, a minus 250 powered labeled contact lens will actually act like a minus 275. So you need to introduce plus power in the distance by using loose lenses. Commonly, you'd be surprised if you haven't done this, how often people will accept that plus power. And we celebrate when that happens, right? Because the plus power helps improve their far vision. What's it going to do to the close vision? It's only going to help that too. So the rule to follow is that offer plus power to everybody. And I only offer minus power to people where I feel like I really need to do it, because patients, I've had this situation where I've had patients pretty happy with their far vision, but then I showed them a quarter more minus and they said, oh, I want that, because they like that increased contrast. But then we started having issues with the close vision. So if they're happy with their far vision, I don't even show them any minus power. It's only if we're troubleshooting and I have to show them minus power, I'm stingy with it, I will show it to them then. And it's only going to be the lowest amount that gets the job done. So I'm going to show them minus a quarter in front of the dominant eye only. And I'm not going to show them minus 50. I'm just going to show them minus a quarter. If that gets me there, I'm going to stop. I'm going to show minus a quarter in the dominant eye, not both eyes, if the minus a quarter in front of one eye gets me there. Again, it's all about finding the right balance. And then if I do all that, I confirm I have the right distance power, then I'm going to follow the fitting guide. You guys, the fitting guide has been developed by the manufacturers to help us. The manufacturers have a wonderful understanding of their unique designs, and they found with numerous studies, as well as now with exposure to clinical practice, what works and what doesn't work. So this is a time to not be creative. When you're fitting multifocal lenses, don't get creative, follow the fitting guide, and you're more likely to get to where you want to go in an efficient manner. And again, if the patient has no complaints, don't change anything. Let's look at a case. So I have a patient here who presented to me. It's a little convoluted here to start with, but she's a 47-year-old woman who came and saw me because she had been fit by another practitioner in daily disposable lenses and multifocal lenses. And she was fit with daily disposable multifocal lenses because she was fit by yet a different practitioner with monthly multifocal lenses way back, wore those successfully, the monthly multifocals successfully, developed GPC. So then a second practitioner refit her with daily disposables due to the GPC, totally reasonable. And she said, I'm having blur at distance and near with these multifocal lenses. Daily disposables don't work for me, was her conclusion. So I was a little puzzled because I knew she could wear multifocals successfully because she had when she was wearing the monthly modality. So here's a little more information on this secretary. Here's her spectacle RX, +4 on the right, +350 in the left, with a moderate to getting a little on the high side of an ad. Her contact lens specs, and these were daily disposable multifocal center near aspheric designs. You can see that in the left eye, +350 spectacle power, +450 contact lens power. Even with Vertex, that's more plus than what you would expect. So the plus is being pushed, and that's also the high ad. So clearly, the left eye is being viewed as the non-dominant eye in this scenario. The problem, the reason she was unsuccessful was that she was in fact left eye dominant, not right eye dominant. So when she was wearing the monthly multifocals, that was recognized, and her dominant eye was fit with a more distance bias correction, which was her left eye. But when the practitioner refit her with daily disposables, her issues had nothing to do with the fact that it was a daily disposable. It's because the practitioner had the dominance reversed. So this highlights the importance of ocular dominance in fitting multifocal lenses. So let's take a second and talk about dominance. How do you determine eye dominance? What technique do you use? There's two main techniques out there used. One's sighting dominance, and pictured here, where you look through a tube or extend the hand and you line something up in there, and then whichever eye lines that up is considered the dominant eye. This is like how you're wired. It's like being right or left-handed. The other technique is sensory dominance, where you introduce plus or blur in front of one eye or the other and ask the patient which bothers them more. And this is more like what we do when we fit multifocal contact lenses, when we have to push plus in front of one eye in order to get near vision, right? So it makes sense to me intuitively that sensory dominance testing, or commonly called plus to blur, is a better way to determine eye dominance. But let's look at science and see what science says on this issue. Science says that in a study done by Pointer way back in 2012, he looked at the two different methods. And I'm going to cut to the chase here and tell you that there was like no agreement between sighting and sensory dominance testing. Further science shows that sighting dominance, there is little to no relationship with success with monovision or multifocal correction. Now, so I know some of you are out there saying, wait a minute, I do sighting dominance all the time and it seems to work for me. So I think I have an explanation for that here in just a minute. There is, on the conversely, there is science to support that sensory dominance testing, introducing plus in front of one eye and then the other, is perhaps more predictive of who will be successful with multifocal correction or which eye should be preferred for distance or near. So let's take another case where I had a physician come in, 62-year-old physician who had worn multifocal GPs for many years, but developed dry eyes associated with rheumatoid arthritis and was on Restasis and omega-3s and eyelid hygiene. He came in specifically interested in daily disposable multifocals because of the ease of care, because he just didn't want to have to deal with cleaning lenses and all that stuff. So he wanted to be able to just wear them and dispose of them. Here's his Ks and Spectral RX. Let me point a few things out to you. So in the left eye, he's myopic in each eye, but he does have that borderline cylinder in the left eye, very little in the right eye, but borderline cylinder against the rule in the left eye. And it is pretty well lined up with his K readings. And he's a high ad. Dominance testing, the reason I have sensory dominance, sensory question mark, is that when I added plus in front of one eye and then the other, it was kind of equivocal on it. And maybe you've experienced this too. Like, okay, went to a lecture where they said do sensory dominance testing, but when I did it, the patient didn't really have a preference. So then I went back to doing sighting dominance. And so now I just always do sighting dominance. Not an unfamiliar story. Again, I think I have an explanation for that here in a second. So I did sensory dominance testing. He didn't have a strong preference, but with sighting dominance testing, he said his right eye was his dominant eye. So I chose to decide that the right eye was the dominant eye. So with my daily disposable multifocal approach, I put a multifocal on each eye per the fitting guide of the manufacturer. And he said, far vision's great, but I'm having trouble up close. How would you problem solve that? Well, what I did was I pushed plus in the non-dominant eye, and the blur persisted at near, no matter how much plus I gave him. I think I went up to 75 or even 1 maybe. He still wasn't happy with his close vision, and I decided, because of this 3/4 up against the rule, astigmatism. I can give him all the plus in the world, but he's not going to be happy with his close vision unless I correct his astigmatism. So my next step was to stay with a multifocal lens in the right eye, his dominant eye, and fit the left eye with a single vision toric and set for near vision, which worked great. He said, oh yeah, I can read great, but he's a physician. He also needed to be able to see his electronic medical health charts at arm's length. And he said, I can't see those. So what did I do then? What would you have done? So I backed the plus off a little bit in that left eye, kept the toric design, but blacked the plus off. And he goes, oh, now I can see my electronic health record, but now I can't read up close. Because with this single vision lens, although it was correcting astigmatism, it didn't have the depth of focus necessary to see all these different distances. So then it occurred to me, wait a minute, a single vision, a non-toric multifocal lens would give him those depth of options. So I'm going to reverse, and I'm going to fit the multifocal right eye, biasing it for near, and fit the left eye, which has a toric lens on, and correct that for distance. So I reverse the dominance. And you know what? It worked. And the question is, the obvious question is, well, how could it work for him when it, obviously the dominance was a key area with the secretary, and when reversed, she couldn't function. Why does it work for this physician? I've developed a test to help me figure out what kind of patient I have in the chair relating to dominance. And this is called doing the blur tolerance test. And I wrote an article about this in Contact Lens Spectrum back in March of 2019, if you want to dig that out. But it basically involves lining up the patient behind the phoropter with the best corrected spectacle prescription. You keep both eyes open through the entire procedure, and with both eyes open, you instruct the patient to report when they first detect blur as you slowly begin to add plus power in front of one eye. Let's say we start with the right eye. So both eyes open, looking at the chart, tell me when it first starts to blur. Plus a quarter, nothing. Plus a half, nothing. Plus 75, oh, it's getting blurry. Okay, make a note of that number. Then reset the phoropter. So we're getting back to best corrected acuity in each eye, and then do the same thing with the other eye. And we're trying to see which eye will accept more plus. And then at the end, you calculate the difference between the two eyes and see which has a higher plus. So when I did that with the physician, he took the same amount of plus in each eye before he reported blur. And now it makes sense why he said with sensory dominance testing that it was about the same, right? What about the secretary? When we take the secretary, she accepted plus 150 in front of the right eye and only plus a half in front of the left eye before she reported blur. So there's a difference of 1 diopter in this case. I then took a series of 16 patients with the help of my colleagues, some of my colleagues in the office. And you can see here, and I'm going to help define this for you here, the bars on the left say that, you know what, there's minimal importance of dominance. These people, as little to no difference between the amount of plus they take in one eye versus the other. Where on the right side, and this is the case of the secretary, where she had 1 diopter difference between the two eyes in terms of how much plus she would take, that person, you need to be really on your game about which eye you bias for distance and which eye you bias for near. But you can see the vast majority of these people in this little series of subjects, there's very little difference. And I believe that's why when we're doing the extended arm technique, the sighting technique, why it works is because the majority of the time, it doesn't matter. It doesn't matter which eye we choose to be the dominant eye. But there are cases when it does matter. So we always have to be looking for that. And I suggest you do the blur tolerance test. It's quick and easy to do to help you determine what kind of patient you have in your chair before you embark on multifocal lens fitting. Also, there was very little agreement between sensory and sighting dominance, just as Pointer found back out in 2012. The last piece of the puzzle that I want to talk about here tonight before we get into any questions is emphasizing the importance of the tear film, particularly with multifocals, particularly with presbyopes. And I can tell you, as a multifocal lens wearer myself, if my lenses aren't wetting well, the visual impact is profound. combined with the multifocal optics, it's profound. So it's important that we assess the tear film. And I know there's a lot of practitioners out there that say, yeah, Tom, I like the idea, but I'm a busy guy, I'm a busy gal, and I don't have time to do a detailed analysis of the tear system while I have a patient there for that their goal is to be fit with contact lenses. So I have some tips for you that I think can help streamline your approach to assessing the tear film. It could be very efficient. It doesn't have to be a separate visit and a lengthy visit. So basically, these are the 4 areas we want to look at. We want to talk to the patient, and we'll get more specifics about that in a second. We want to know about tear quality and tear quantity. How much do we have and how good is it? And is there a sign of inflammation? So how do we do that? There have been a number of studies actually looking at the different questionnaires that are available out there. Some of you may have employed some of these in your practice. And they based this study here, quoted here, done by Simpson, showed that they all give you about the same information. And if you say, well, you know what, Tom, I don't even want to do that. I'm okay with that. You can just ask the patient these basic questions. How do your eyes look? How do they see? And how do they feel? So how do they look when you look in the mirror? Are they red? Again, sign of inflammation. How do they see? Is your vision fluctuating a lot? Does it look filmy? You probably notice this with patients that have a poor tear film. They won't necessarily report blurry vision, they'll report filmy vision, particularly if you ask them directly. Is it blurry or is it filmy? Oh yeah, I think filmy is probably a better word to describe it. And then how do they feel? Obviously with dry eyes, discomfort with gritty feeling. So if you don't want to use the questionnaires, ask them those 3 basic questions. How do your eyes look, see, and feel? If we want to then take a moment to evaluate tear quality, I'd want to put staining in to assess the anterior surface of the eye anyway before I fit them with contact lenses to look for dryness. Let's go ahead and throw a cobalt filter in there and see if we have breakup of the tear film. Quick, easy to do. And then if there is poor tear quality, so the tear film breaks up quickly, that's because there's issues with the oil, right? And the oil comes from the lids. So I'm going to take a look closely at the lids, looking for oil caps like you see here. I want to push on that lid to express the contents of the glands. You can get Mastrada paddles and all kind of fancy devices to push on the lid, or you can use a swab, or you can use a clean finger. And you know what? If you're pressed for time, a clean finger will do the job. I want to make sure that oil expressed out of the gland looks like an oil slick. I don't want to see a lot of particulate matter. I don't want to see toothpaste coming out of, thick oil coming out of that gland. And I have been impressed by the number of times when I've just looked at the eyelid and thought, oh, it looks pretty good, only to find that when I push on the gland, the contents of the gland are not good. So you can't just rely on that external assessment, although the external assessment is really important. And I found that oftentimes a kind of a beefy lid is more easily seen with the external examination, but that is while I'm talking to the patient at the beginning of the exam. I'm looking at their eyelids, because you get them behind the slit lamp, and sometimes due to the magnification, you lose perspective and you can't appreciate that the eyelids are a little thick and a little beefy and a little bit red. So make sure you're stepping back and taking a look at the patient to help you with this assessment. Looking at tear quantity, the DEW study, we're going back to science here to help us in deciding what's the best way to tell me how much tear is there. And they recommend looking at the tear meniscus here at the bottom of the lid margin. This is normal. This is dry eye. So you got to do this regularly so you have a sense of what is normal. If you just wait till you have a patient, you think, oh, I think they have a dry eye, and then look, you won't have anything to compare to. So please do this on every contact lens patient. It's quick, it's easy, and you develop a sense for what is normal versus abnormal. Inflammation. Mentioned this earlier. The patient's eyes are red. That's a sign of inflammation. And the reason you have to look for inflammation is there are other conditions, such as some binocular conditions. There was a great study by Aaron Roof that showed that some binocular issues can manifest themselves as patient complaining of dry eyes. So, and to make sure that we truly have a dry eye, you will have some conjunctival injection associated with the inflammation that comes with the dry eye. So a lot of words, but really it just takes a moment to say to the patient, how do your eyes look, see, and feel? Let's put a little fluorescein in here. And while I'm getting the slit lamp lined up, I'm looking at your eyelids, seeing how red and beefy they are. Then I'm looking for tear breakup, and I'm looking for tear meniscus, and looking for redness. So it just takes moments. And it's so important, guys, and gals, because I say, if you need a good environment for this contact lens to live in. And if you have a bad neighborhood, don't be surprised if bad things happen. You need a good neighborhood for the contact lens to flourish in. So how do we treat tear film issues? I'm just going to touch on this briefly because that's a whole nother talk. But just to be complete, we're going to make sure if it's a quality issue, it's a problem with the oil. So we're going to clean the lids. We're going to apply heat with heat masks. Using, so the water run out of the tap is not effective. There have been studies by Blackie and Korb that shows you need to have heat on there at a high temperature for at least 10 minutes to have a therapeutic effect. So really, we need to use heat masks, and they're widely available now. And if you're not using them, I encourage you to. I've had a number of patients come in and say, I'm going to buy a heat mask for my friends because I find it so relaxing, and I like to do it at night before I go to bed. And it actually turns into something that helps motivate them to actually do it. And there's orals you can do with fish oil and doxycycline. If there's a quantity issue, we're going to use anti-inflammatory drops. There's a whole mess of them right now. I mean, not mess, I mean, a number of options, which we are blessed to have. Punctal plugs, goggles, things of that nature. So that's how we manage that. Now I want to shift gears a little bit and talk about the comfort issue. I touched on it briefly there, talking about dry eye assessment. And this is a really cool study because it looked at end of day comfort in patients that were wearing re-wearable lenses or reusable lenses using either multi-purpose solution or hydrogen peroxide, and then compared that to wearing a daily disposable lens. And you can see this is statistically significant difference. Daily disposables were more comfortable than either multi-purpose solution or hydrogen peroxide using patients. So daily disposables offer wonderful comfort. The thinking is because both multi-purpose solutions and hydrogen peroxide can affect the smoothness of the lens surface. There's some science to back that up. So daily disposables, great comfort, and it makes sense for a presbyopic patient who is more likely to have a compromised tear film, and therefore more likely to coat a lens, and therefore more likely to have variable, foggy, filmy vision, and also comfort issues, that we fit presbyopes with a daily disposable. So that is my first recommendation for every multifocal contact lens, soft contact lens patient. You may say, Tom, well, I appreciate that, but what about the cost? We optometrists worry a lot about the patient's pocketbook, and I get that. We're good folks, and we are concerned about the patient in many ways, including their pocketbook. And I always cite this study done by Robin Chalmers, and I actually cite this study for any daily disposable patient, be it single vision or multifocals. And I say that, dirty lenses create most contact lens complications. And the studies have shown that if you replace your lens every day, it's not twice as good. It's not even 10 times better. It's 12.5 times less likely to create eye irritation. And the patient hears that. And then you have to put it in perspective for them by saying, that's a big number. And then they kind of like, oh, okay. You get their attention. And when you talk to them in that way, that helps them understand that a daily disposable lens is going to benefit them directly, then cost tends not to be that big of an issue. particularly for the presbyopic patient who controls the purse strings, who doesn't need to go ask someone for permission to embark on this multifocal adventure. So I find very little resistance, particularly again from the presbyopic patients. And you may say, well, should it be a silicone, a daily, a hydrogel, or a Sci-Hi lens? Doesn't matter. Robin Chalmers again and her colleagues did another study looking at that. And in each case, results were very, very good. Okay, I'm going to close on this. When is enough enough? You've been fitting a multifocal patient and they keep coming back, and you say, when do I say, you know what, this isn't going to work for you? Here's a few ways I think about it. First of all, I've done my due diligence. I've confirmed I have the right prescription, as we've already described. Then I share what I call the 3 revelations. The first revelation is, and I've mentioned this already, my goal is to meet most of your visual needs most of the time. And that's shared with them at the outset, right? We've talked about that. But if they come back and they're still not happy, and I know I've done everything right, I've got the powers right, then I share this revelation. You may need to give up a little bit of crispness for freedom. Give up a little bit of crispness for freedom. That's the trade-off. So if you like freedom, give up a little bit of crispness. And oftentimes that gets patients to where you want them, because psychologically they shift a little bit, go, okay, yeah, because I can do most everything I want. It's not quite as crisp as my glasses, but I can do most everything I want. So they're happy. But some people aren't. They'll come back and yet again complain and say, I'm not quite where I want to be yet. And that's when I reveal the third revelation, which is, this is as good as it gets. And I've been amazed the number of times patients go, oh, okay, well, I mean, it's okay. It's fine. I just thought if it could be a little better, I want it to be better. And that is so important, folks, that you appreciate that some patients will push you to want it better and better and better. And then you start chasing that and you upset that balance we've been talking about this whole time here. And then you're really swimming upstream. So if you feel confident that you've got them as good as you can get them, sometimes you need to just say, this is as good as it gets. And they accept that and they're happy.